welcome to this meeting, this inquiry session of the NHS Innovation and Life Sciences Commission's Dementia Programme. My name is James O'Shaughnessy, and together with Mike Buick, we are co-chairs of the Commission. And on our behalf, as well as Corinna Bulls, Keith Ridge, and Gillian Lanes, I'd like to issue a very warm welcome to you all and thank you for joining us, both to you as attendees and, of course, to the panellists who we will be speaking to today. As you may know, the purpose of this programme is to explore the nature of the health crisis that we face with dementia. It's one of the biggest health challenges of our generation. We know 1 in 3 people is likely to develop disease, with 1 million people in the UK predicted to have dementia by 2025, with huge social health and wealth costs. But at the same time, there is a wall of innovations, therapeutic, diagnostic, changes to care pathways and so on that offer real hope for change. And those are the items that we are going to be exploring today and have already had the opportunity to explore through our first session, which took place in May, which looked at future technologies for patients. What we're going to be doing today is a 3-part session looking at population health and patient engagement. The first session will be looking at population health and preventative health. The second, which will be looking at improving health population through innovation. And the third is improving engagement and tackling stigma. So in terms of the format, I will shortly introduce our speakers for the first session. They will speak for, introduce themselves and speak for a couple of minutes. And then we will have an opportunity to ask questions. We have some questions as commissioners lined up, but strongly encourage you to use the chat function, both to comment on the discussion as it goes, but also to post questions, and we will keep an eye on that and try and pull on that where relevant. So please do feel that you have the opportunity to contribute, whether it's, as I say, in commentary or in questioning. If everybody is happy, and Alexis is here, perfect timing, then we have all 3 of our speakers, so I will move to them quickly. Before I do so, I just want to express my gratitude for the partnership support provided by Lily, Roche and the Alzheimer's Society for this programme. So if I can move swiftly on to our first session, which is, we have the speakers, Professor Lynne Corner, Alexis Chappell and Sebastian Walsh. Lynne, Alexis and Sebastian, I'd like you to individually introduce yourselves, if you will, as well as give your 2-minute opening statement, and then we will move into questions. So, Lynne, could I come to you first?
Hello, everybody. Delighted to join you today. My name is Lynne Corner. I'm a professor of gerontology at the UK's National Innovation Centre for Ageing, where I'm also the deputy director. I'm also the director of an organisation called Voice, which is a citizen network now in 11 countries. And that is there to help understand the needs of citizens, particularly the unmet needs of citizens, and mobilise their brain capital in order to support research and innovation. I'm also a trustee of the Lewy Body Dementia Society and founded the International Lewy Body Society. So perhaps today I will be looking at this issue through the lens of people, citizens, patients and carers. Back in 2010, I also launched the first national strategy for dementia and the first regional strategy for dementia. So very, very interested in the work of the Commission today.
Alexis, would you like to introduce yourself, and then Sebastian, and then Lynne, I'm going to come back to you for your opening statement. Thank you for joining us today. Alexis.
Okay, so my name is Alexis Chappell. I'm the Strategic Director for Adult Care and Wellbeing in Sheffield City Council. I'm really delighted to be here today, I think, because this gives a really good opportunity to talk about actually how do we involve people living with dementia in achieving the very best outcomes for people. And I say that because that's actually one of my key interests and one of my key areas for development within Sheffield is about how we take very much literally the approach of nothing about me without me. And because I think that's absolutely a way in which we get not only the very best health and social care, but it also means that we focus on people's strengths and assets and actually very much focus on what people can do and how we go forward. So that's what I hope to bring to the table today. And I'm also joined by Jo Pass, who is an assistant director from Living and Aging Well within my team, and who's done a really great piece of work and actually leading across our dementia strategy across Sheffield.
Great. And Joe, I hope to come to you at some point in the next 35 minutes for you to talk about that. And then Sebastian.
Well, I'm Seb Walsh. I'm an NIHR doctoral fellow at the University of Cambridge and a public health medic in the east of England. And my research is particularly focused on population level approaches for dementia risk reduction and thinking about equity in that. And then through the public health work in the local system, so seeing the pressures that some of our services are under at the moment. And I work with Professor Carol Brain at Cambridge, who's done a lot of the key epidemiological work into dementia in the UK, but unfortunately couldn't be here today. But I'll do my best to fill her rather large shoes.
Thank you, Seb. Delighted you could join us. So, Lynne, if I can come back to you, the purpose of this first session is to explore, obviously, a population preventative approach to dementia, which obviously you, Seb and Alexis, are fantastically well set to give us advice on. We also want to explore this issue of earlier and more timely diagnosis in community settings, which came up a lot in our previous session, and the distinction between early versus timely diagnosis, because of course those are not necessarily the same thing, and they connote different consequences in terms of care pathways and so on. But Lynne, can I come to you first to give your opening statement, and I'll come to Alexis and Seb, and then we'll move into our questioning. And if I could ask you to keep to 2 minutes, that would be great. Thanks.
Yeah, thank you, James. I mean, I think for us to start with kind of prevention is in terms of kind of obviously, you know, the context of life expectancy beginning to stagnate in the UK and in the US and elsewhere. We're spending vast amounts treating chronic conditions, which is actually post-diagnosis, but you know, only 40% on, you know, the preventable conditions. And fifth of UK citizens living in poor health, 20-year difference in life expectancy. I'm sitting here in the northeast where it's particularly you know, an issue. So, you know, this has got to shift to, you know, a prevention kind of mentality instead of just focusing on just the diagnosis and post, you know, treatment. To look at proactive prevention has really got to be the issue. And we need to radically reimagine both the short, medium and long-term responses at both a global, at a societal, and perhaps particularly at an individual level in order to kind of really invest in a connected ecosystem that is going to address this, because it matters to both current populations and obviously future. We also feel, when we've worked with Voice and we've actually listened to citizens on this, that there is a real strong feeling around a waste of existing assets and a lot of duplication and a lot of waste in the system. And actually, from a citizen perspective, prioritizing the effective joining up and the coordination of key organizations and the resources to accelerate this issue is absolutely critical. People are quite incredulous around the lack of data join up, for example, appreciating the challenges. But the fact that GPs and some systems still do not connect is a massive issue in both the diagnosis of dementia, but also in post-treatment. But, you know, also really exciting in terms of the potential that is coming through in terms of AI solutions, etc., to tackle these big real problems. And really a plea to invest in brain health and brain capital across the life course, because obviously in order to prevent dementia, we're really interested in looking at those behavioral aspects and those that investment much upstream in terms of how we can nurture brain health and brain capital in order to you know, prevent a lot of you know, cases of certainly, you know, cardiovascular type dementia. But that seems to be an area that citizens are really interested in. So I think leveraging technologies, mobilizing brain capital, really focusing on intergenerational engagement is something that we feel is extremely important in terms of prevention, in terms of brain health, looking at resilience and self-esteem. But then how can we also democratize access to a lot of information, looking at digital health literacy and health literacy, because so much of the benefits of what we can leverage from the prevention and, you know, is really kind of not accessible to so many people. So actually, you know, looking again at both health literacy and digital health literacy as part of the prevention landscape seems to be absolutely essential. Finally, I think that people that we've spoken to are very, very interested in terms of how the personalization agenda is going to play out for people with dementia, not just looking at dementia as prevention, but looking at multiple morbidities, looking at the connections between different conditions. And how that can kind of be leveraged by kind of more collaboration through the system. There's a huge and exciting potential, I think, to kind of co-design future digital solutions with people, which are very much tailored to their specific circumstances and meet their complex and changing needs, because every person with dementia is obviously different. So there was great excitement amongst citizens in some recent groups that we undertake, around about 1,000 citizens, about how that might be achieved. So certainly public interest in prevention of dementia remains very high, but confidence in investment and ability to achieve it is very mixed.
Thank you, Lynne. Lots to pick up on in your statement. Thank you. Alexis, can I come to you next?
So 3 key points. I think first for me, I'm going to start off by actually is about involving people. And I say that because I think it's really important that we ensure that people's views and voices are absolutely central to how we gain early diagnosis. And I think across a range of cultural groups. And one of the key particular things I think is really important is that we also think about the BAME community and how people support signs across the piece, because and one example I've seen in Sheffield that we've undertaken is actually launched videos in Urdu and Arabic so that people are aware of early signs of dementia and how to get help. And and for me, it's an area in which we're going to continue to work with colleagues and individuals in the BAME community to go and to really develop further, so that we're absolutely reaching out into communities that perhaps are being seldom heard. Equally, what's really important is that I started off by saying nothing about me without me, and I think it's really important is that for people who are living with dementia, is that their views absolutely help us to think about not only the technologies but also the supports around and the early signs that will help us to kind of find a early diagnosis. An example is we recently commissioned Deepness Dementia, who are a charity within Sheffield and across actually the UK, and they particularly looked at the subject of unconscious bias around dementia. It's a really good piece of work that they've undertaken, and I could link with the colleagues within the charity to share some of their research. But particularly to me, what's really important about that is actually valuing the voice of people living with dementia and how not only people could live independently and going forward. So that's my first kind of point about involving people. The second point is actually about using our social care workforce. We have got a very large social care workforce up and down England, and also, I'm going to say because my very Scottish accent here, but from Scotland as well. And I think that what's really important is that we also look at how do we value and train up our social care workforce to spot the early signs of diagnosis, because it's very likely you'll have that very large workforce, whether it be PAs or social care workers out there working with people in communities, and they could be a valuable intel and insight. And I say very practically within Sheffield, what we've done is recommissioned our home care services, and we're in the process of further developing our PA supports so that we can absolutely have that ability to have early signs and symptoms as part of core of what we do, as part of our core enablement functions, as how we take that forward. And to me, alongside that, and my third point is about the integrated working with health colleagues, is because one of the key things I think is that you'll find that you'll have social care, health staff, different sectors involved working with people. And for me, it's how you join up the conversations. And, and I'm going to say this, I've been around so many years in which people have talked about shared IT systems. For me, it's also about conversations and how we actually have conversations at a multidisciplinary level, because actually that can help to sometimes see the early signs of either early signs of concern, but also early signs in which there are ways in which we can support a person at a very practical kind of level. So particularly within Sheffield, what we are doing is joining up between primary care and healthcare, primary care and social care services around primary care networks in local neighbourhoods across Sheffield, so that basically what we could have is that very much joined up one version of the truth and very much that single joined up story for the point of view of individuals. And that will hopefully then help us to get to very much a key point where we could spot things collectively together, and intervene earlier to prevent future harm, but also to enable that person to live an independent life. So 3 key points about people, our workforce, and actually how do we join up health and care services. Finally, the only thing I would say is that there's a huge amount of technology-enabled care out there now, which is really developing, and I think that's areas in which we could really further develop. And we've got a national conference in September in which we're going to particularly look at how do we use technology to not only promote early diagnosis and early intervention, but for me it's also about how to enable people to live more independently, which is also the other side of it as well. And so that's hopefully 3 quick points that helps us to move us forward.
Thank you, very good, and lots to unpack there, which we will return to. Thank you. Seb, can I come to you?
Yes, I agree with much of what Lynne and Alexis have said, and I'm happy to talk about diagnosis when we get into the Q&A, but my focus really is on the population prevention side. And so if I use my 2 minutes for that, I came out of clinical medicine looking after people with dementia into research with one question in my head, which was how do we prevent the most amount of dementia that we can so that the generation coming through have less than before. And I think that on that, we have a mismatch between how we think about dementia prevention currently and what the evidence tells us we should be doing. So I think currently we talk a lot about what individuals can do to reduce their risk. You see 100 articles in the Sunday papers about what can I do, 5 things to boost your brain health or 5 things to this, and that's absolutely fine, and we should encourage it. But what we don't have is what the evidence tells us really would be our best avenue, which is policy level change and change in population level risk factors. So we've seen from the cognitive function and aging studies, the CFAS studies in the UK and then elsewhere, that prevalence of dementia dropped age specific. So pound for pound, if you're an 80-year-old in 2010 in the UK, you were less likely to have dementia than in 1990. And the reason that drove that is probably better public health measures throughout the 20th century, better cardiovascular health, more education, less smoking. And the way you tackle those things, we can draw evidence from other conditions and other non-communicable diseases, and that is by changing policy. And the other big reason for thinking in those terms is about equity. So we know that if we encourage individuals to change without changing their social determinants and making it easier for them to do so, then we will see benefits for the most affluent and for those with the highest agency and resource, and we will see a widening of health inequalities. And in fact, in that CFAS data, the UK data that showed the drop in prevalence, the drop in prevalence in dementia was exclusively seen in the richest and best educated third of people. There was no change in prevalence for the bottom 66% of our society. So I think equity and maximum prevalence reduction comes from policy change, and what we're doing at the moment is trying to bring that evidence together, and we're very happy to share that with you as it comes through of what those interventions would look like.
Excellent, thank you, Seb. And I think one of the many themes that's come through here is obviously the link between physical health and brain health. A holistic view of health will have brain benefits as well as having a range of other benefits, and we should never forget that this is part of a wider view of preventative health and as you said, the role of social determinants and so on. Lots to get us going with. I'm going to hand over to Jill, who's going to ask the first question. So Jill, can I hand over to you, and then I'm going to come to Keith, Mike and Corinna if we have time.
Thank you, and morning everyone. There's obviously stuff we can do at a community local level, and there are wider public health approaches around raising public awareness, and it's that wider public awareness I just want to ask about in terms of, are there any practical strategies that we might employ to raise awareness of getting an early diagnosis, because we know that's not always something that people are keen to get. And Lynne, I'm going to target this question to you, if I may, because you talked about digital and you talked about systems and how we might do that. So any thoughts over and above what you've already said, and indeed examples that we might learn from?
I think the emphasis on early diagnosis is very welcome, but also we need to look at the support post-diagnosis from that early diagnosis, if that makes sense, because at the moment what happens is that we are encouraging people to have an early diagnosis, but there are woeful services in some places to support that experience post-diagnosis. So, a join up of the conversation around getting a diagnosis and making sure that we have got, adequate support, psychological support in many cases in the early stages to support people through that journey is something that, is absolutely essential. I do think it comes down to data a lot of the time. We are finding still that, for example, GP data, I know it's a well-rehearsed issue and it's a well-rehearsed challenge, but this massively impacts on patient and carer experience. The fact that services are not joined and therefore we can't necessarily get the best pathway for people post-diagnosis. So when I talk about kind of the system change, I absolutely understood what the previous speaker said in terms of investment in health and social care join-up, but I do think that actually investment in kind of the data join is something that is absolutely essential in order to leverage the existing assets that we have, and there are many. But they are unconnected, often therefore inaccessible to patients and their families.
So do you think that there's a barrier around awareness of the need for an early diagnosis? Or do you think most people know that they probably should get a diagnosis, but they're put off by the fact that they don't think the help's there?
Absolutely. That is a major burning issue that I think over the last decade, the PM's challenge on dementia was fundamental in raising awareness. I think there's been a huge amount of success and progress, lots more to be made, but I think there is progress in terms of raising awareness of dementia. I do, however, think there is a despondency amongst families about what can be done following that diagnosis of dementia. And so that is as important to focus on as just the diagnosis process.
Thank you. I think it's Keith next.
Yes, thank you, Jill. I just wanted to sort of draw out that point as well, which I think we need to come to, which is how you address that kind of helplessness, hopelessness point. In terms of the fact there are things you can do even once you have got the onset of dementia in order to delay the disease, and we don't have a cure yet, of course, but there are a range of interventions that can make a difference, and there clearly isn't a very high degree of understanding about that. Hence, I think that despondency, Lynne, that you're describing. Keith, can I come to you?
Yep, thanks, James. I want to ask Alexis, who I think made 3 valuable points from a social care perspective, but I wanted to ask her to describe, if you wouldn't mind, Alexis, what happens from your point of view when there isn't join up. Can you just sort of picture that for me? I've got another question about primary care clinics and diagnosis as such, but I just wanted to pick that up, just for if Alexis could just describe to us what happens when that join up doesn't happen.
So I think for me is if I think about it from a point of view of individuals, and often when I speak to individuals, is often their experience could be is where what you've got is different professionals being involved and the multiple communications that they have to then undertake. And so if you're a family member carer, for instance, and you're looking after an individual and you're having to go across multiple agencies, actually the data point is a really good point, because actually the key thing will be is the time that takes from a point of view of people. So if you think about it, if you're, I'm thinking about this on 2 points, if you're a family member carer and you're having to work across different professionals to understand what's going on, then actually that's a lot of time and effort when you're also trying to go and trying to look after and support your loved one. So through a rather challenging period in your life, and it's all the the kind of anxiety and the stress that could cause. So for me, I think I think about this particularly from a family member carer point of view, but equally, if you're an individual, what you'll be wanting to know is what's going on with me. How can I get the right advice, the right support to try and help me to go and live my life and the life that I want to go and live. And so for me, one of my key commitments I've always made, particularly within adult care, and actually I've worked across health and care in my career, is that we make things as joined up and as streamlined and as straightforward as from a people's point of view, so that people could get the right support at the right time. And even if, you know, and I have this view, it's even if people are going through the process of diagnosis, from my point of view, it's in social care is what can we do to help people through that process, you know, both from a carer point of view and through from a point of view of an individual's point of view, so that ultimately people have the most best experiences that they could possibly have. And so that's where I come back down to, you know, and you know, it's very much likely on this call that 1 in 9 of us will be a carer at some point in time. And you know, and so I think that, you know, that's real life statistic that's there, and so for me, you know, I think it's really important that we do get things right, you know, from that point of view, both from the point of view of the individual themselves and also from the point of view of family member carers. So hopefully that's quite helpful, and I think Joe, who's my colleague, wants to come in as well. Can we add a few words?
Yeah, I was just going to say that you know, for some people, are able to chase around trying to repeat their story in a very disconnected, unsatisfactory way, but for others they don't, and they just fall through the gaps. And actually, when the systems, whether that's healthcare, social care, do actually pick them up, they are invariably in crisis, and it takes a lot more intensity of resources at that point. But then the other side of that, which is really awful, is that if they'd had that support earlier, we may have been able to prevent or delay some of the experiences that they're now presenting with in crisis, and so that the individual loses a bit of choice and control in that situation that they would otherwise have had. And I do think that a lot of this comes back, you know, there's the connectivity, but there is, as James has just articulated, the stigma and the fear. And I think that we have a lot of assets on the ground that can help support us to tackle some of that stigma and fear.
Okay, that's really helpful to have that, you know, description from your perspective. I wonder if I could then ask Seb about community settings, whether primary care clinics or community health centres, and how they can be used effectively for diagnosis, for dementia diagnosis. Seb, have you got a sort of view on that?
Well, I agree with everything that's been said, but we've mainly heard the argument for timely diagnosis on the basis that it needs to therefore link into better post-diagnostic support for those people. And that is an argument I'm very happy with. The idea, and that leads us to use the phrase timely diagnosis. The push for early diagnosis is a different concept, and I think we have to be really careful with this. So at the moment, most people who are diagnosed with dementia in the UK is in their 80s. And in contrast, I think what you kind of see a lot in the media, a lot of the discussion is sort of about, particularly because of the drugs which are coming through, where they're trialing these in people who are 65 with amyloid in their brains, but no other sort of comorbidities, very, very specific population. And I think people are equating the two things together. And when we talk about early diagnosis, is this sort of logic model of we get people when they've got amyloid, they've got nothing else, we give them this wonder drug, they get better. And I think there's a big departure between those two things. So we have to return to the epidemiology and the actual population who are suffering from disease. And this is people in their 80s with mixed dementias, with complex needs. And one point I would just like to make, though, is that everyone attending a memory clinic or their GP with some kind of memory complaint, with functional impairment, every one of those people has some needs. And actually the label that you then put on their symptoms, whether that is mixed dementia, vascular dementia, or Alzheimer's, or actually a non-dementia diagnosis, doesn't actually change the needs they have. So I'm all for timely diagnosis. I think the data linkage is very important, but actually if you take that person-centered approach, it's what are the symptoms this person has, what are the needs of the carer, and how do we best meet those? And I think actually that's the focus, and we should talk about timely diagnosis in that context. I'm a bit uncomfortable with the early diagnosis because it starts to move us towards a conversation about screening and things that we, they're very different concepts.
But if that was to be done more in primary care, in its various settings, so are there sort of other key considerations to sort of think about if that's going to happen?
Yeah, so I just before I decided to focus very exclusively on research, I was working at an integrated care system, and there we were talking about trying to move some of the memory clinic personnel into primary care network settings. And my feeling is largely unchanged since that time, which is that if the system all works as we say it does on our documents when we write the care pathways, that's a great idea. But actually we know where the system is at the moment. So I think we have to be careful again. I'm sorry to continually be the voice of cynicism, but we have to be careful that we're designing a service around the system we currently have and that we feasibly are going to have in the next 5-10 years, and not the one that we'd like to have when we write the service design spec on the piece of paper. So I'm not sure at the moment where we are that moving it from memory clinics to primary care or anywhere else is going to be some magic bullet that will massively change any of the issues we're talking about. Clearly integration of workforce and data will help to pinpoint some of the issues, but actually, you know, the issue is the system is drowning, and we have massively higher demand than supply, and that has all these knock-on effects, and it will affect people with dementia more than anyone else, as we know. So I'd be wary of saying that is the sort of a simple solution. I'm not sure it would make a huge amount of difference given the pressures on the ground at the moment.
Okay, thanks. I think handing on to Mike, I think.
Thanks very much, Keith, and good morning, everyone. Seb, just building on what you're saying, that changing the sort of deck chair's position might not be the most valuable thing to do at the moment. Perhaps raising awareness and the training within and resources to train people in early diagnosis might be across the system worthwhile looking at. Have you any experience of how that's been rolled out in the new sort of integrated world that we're meant to be in at the moment, in terms of making sure that staff have got the skills to pick up the actual diagnosis early or timely?
I suspect the other panel members might have a better answer than I do. But I mean, there are definitely really good training programs out there to raise awareness of. Mostly, I think it's about actually making sure people know how to deal with people with dementia when they have the symptoms, and making their healthcare experience the least bad it can be. But I suspect the other panel members will have more to say on that.
We'll go to Lynne then. Thank you.
I have an automatic mute session, sorry. I think it's fantastic that the UK has invested so much in multiple conditions, and I think that is where the emphasis needs to continue to be, because people with dementia, as previous speakers have said, are obviously going to be on the whole older and also have kind of many multiple conditions. So looking at that kind of holistic approach is really, really important. And then training all health professionals, but especially perhaps primary care physicians, to have that kind of multiple morbidity approach is absolutely fundamental. I also think that for the experience of dementia, the other health professionals, dentistry, for example, pharmacy, chiropody, physiotherapy, and so on, are absolutely fundamental. And I think their role is often underplayed, and yet they play a huge role in early identification, but again need clear pathways of where to refer onwards. So that remains really, really important, and not just for diagnosis, actually in terms of the experience of dementia later on. Really, really important. I also think that professions like dentistry really need a second look. Because, you know, in terms of public health, in terms of inflammation, and in terms of, you know, the woeful state of community dentistry at the moment, we absolutely need to look at that in terms of long-term prevention of, all sorts of kind of later life problems. But again, these are assets that we have. They can be kind of readily trained, but the feedback we have from dentistry is that they simply don't understand yet the pathways with which to refer.
I think you make a really good point around the fact that primary care isn't just doctors, and that I know Keith, my colleague on this, would wax lyrical on it in terms of the role of pharmacists, for instance, but certainly dentists, ophthalmic opticians, etc., are all going to meet these people long before we've made a diagnosis of them. Alexis and Joe, you both put your hands up, so we'll start with Joe because you had you up first, Alexis, if that's okay.
Yeah, I was just going to come back really to the point Alexis made, in that we have invested in training all our frontline social care practitioners, those delivering care and support around dementia awareness. Now, we have been focused on actually providing that care and support in that enabling way for people that are post-diagnosis or at least have the symptoms of dementia. But the potential for the army that we have up and down the line of carers on the ground to support that awareness and tackling some of the stigma around the diagnosis of dementia and highlighting the support that is available. It is really there. I also just wanted to mention that in Sheffield, we're just waiting for the analysis on a pilot that we ran with our GPs, who were doing their annual dementia reviews in community settings like dementia cafes, etc. But they were doing it alongside voluntary sector partners. And we know that that kind of holistic approach that's looking at social care alongside the GP care in an environment that the person feels familiar and is much more comfortable in is really one that's bearing fruit for us.
Can I just step in at this point? Sorry, Alexis. I'll come to you just briefly, but just to say, David, I have seen your hand. I sent a message saying I would come to you. I don't know if you'd seen it, but I'll perhaps come to you after Alexis for a brief comment, please.
James, I'm happy to give my question time to David. That's not a problem. Keep us on track.
Thank you.
So two very brief points is, number one is around our care workforce. We have a significant and large social care workforce across England, and that includes not only social care practitioners, but also social workers, occupational therapists, and social care practitioners. And and I think that's a workforce which could be invested in, supported, to particularly around early diagnosis. And it's that workforce who will be in communities right across England, and who are accessible, and who will likely be the ones who will be spotting some of the early concerns. So my plea would be is to look at investment in social care. I'm not just saying that because I was a director of adult social care, but actually I think that's an untapped workforce that could be really supportive, particularly to this agenda. I think secondly, and there was somebody actually raised it within the chat, but I was going to say, if you think in a really practical point of view, people will go to their community pharmacies and to seek advice sometimes from a pharmacy about actually just about straightforward things. And it's actually in your local communities that people will see a difference in people's presentation. And one of the key things that we're actually doing in Sheffield is actually we're involving a co-production network to link it to not only to our BAME communities, but also to our communities to go and look at how do we think about the kind of supports and access and natural resources that are around in communities across Sheffield. And I say that because that's another untapped kind of resource that we need to think about as well, is actually where community assets and community resource. Community pharmacy is one of them, but you also have a range of other kind of voluntary sector who will be supporting people in a range of different facilities, and actually will know changes in people's presentation. So I think it's really important that actually we think the wider workforce of kind of social care, as well as voluntary sector, as well as your PAs, as well as what's in communities as well, if that makes sense.
Thank you, Alexis. David, can I come to you for a brief comment? And we are going to need to move on because we've got these three parts today. So please do speak.
Quickly, I think there's a resource in the community that, particularly around for Black, Asian, minority ethnic communities, that's completely underused and inadequately invested in. I mean, we've seen with the COVID experience that they've been able to get out to communities that have just not been reached for COVID information through their own ingenuity and devices and connections. And I think we need to remember that a lot of dementia care is being delivered in the community. And so for some of the communities that are at highest risk of dementia, like the Black, African, Caribbean and South Asian communities, they're not going to the GP, they're not accessing some of the kind of resources that we're talking about now, but they are going to the mosque, and they are going to churches, and they are having conversations in the shops, and they are going to hairdressers, and they are going to sessions in their own community groups about health information, about dementia, and a whole bunch of things. And quite modest investment would really help those community organisations get the message out, so people understood dementia more and were more likely to understand the pathways and be more likely to actually approach services. But it needs some proactivity on the part of services. I think it's much better done, I think to your point really, Alexis, on a local basis. But it needs to be robust and proactive. It's no good waiting for folk to come along, because we just won't.
Yeah, very good point. Thank you. And I think what we've hopefully heard from Alexis is some very, as you say, specific and local examples, and are not the only ones, I'm sure, of course, about what that looks like. And as you say, the kind of broad community deployment. I'm thinking about public health campaigns around spotting people having strokes, for example, which is about destigmatizing disease, allowing people to have, I know, obviously an acute incident of a health problem rather than a chronic one, but nevertheless, actually that is a sort of educative piece, which is about tooling up every person to be able to intervene, or at least to have a word to guide and so on. And there's a lot of obviously sort of subtlety needed in how that communication takes place. Well, we could keep going, I know, on the subject, but we do need to move on to our next session within this inquiry. So I want to say a very sincere thanks to Lynne, to Alexis, to Seb, to Joe, and to everyone else who's contributed through the chat on this topic.